Luis Borba is here, and we would like to, Luis Borba being a star of skull-based surgery, we would like to hear something from Luis as well. Luis, are you here?
Yes, sir.
Yes.
All right. Welcome, Louis.
Hello. First, I'd like to apologize that my connection was not okay. As I was watching Dr. Wang's presentation. During my career, I did a lot of patients. I treat a lot of patients with trauma. A lot. Always the brain was swollen. Always the brain is very angry. And there is something that you are changing, you are to treat these patients. But I don't think that we treat, from the bottom of the heart. We as a neurosurgeon, we treat the trauma the same way that you treat brain tumors, skull-based tumors, aneurysm, cavernomas. Sometimes the trauma is slipping away. See? And I think we didn't use, I say me include, we never used the microsurgical techniques in trauma. I don't know why. Not the techniques by itself, but the ideas to relax the brain, to perform better understand of the physiology. And I want to say something. When I met Dr. IP many years ago in me, he gave a lecture about cisternostomy. I didn't believe. You know why I didn't believe? Because I trained a lot of trauma and the brain was coming out. But never in trauma, in contusion. I went there and did microsurgical techniques, open the cistern, communicate the thing. And after that, I started doing some case. Large contusion, went there, the cistern communicate, take CSF leak, the brain come out, and the blood supply to the brain is coming. Our goal in the trauma is to bring more blood to the brain survive. If you relax the brain, the blood will come. And I used to do skull-based tumors, especially when you're dealing with the temporal lobe, like Antero-Petroso approach. We used to use to put lumbar drain. But the brain was not always well relaxed. And the temporal bone was, the temporal lobe, not temporal bone, temporal lobe was a big issue. You put lumbar drain and the temporal lobe still was there. And I start to change my approach to reach the frontal lobe, go to the basal cistern, open the basal cistern, not take a little bit of CSF leak, not just release a little bit. Went down and released a lot of CSF leak. After that, I come to the middle fossa, do the peeling of the middle fossa, and the temporal lobe is completely relaxed. It's completely different surgery. Professor Vladimir, I think he was online here, he can say to us, Professor Yashagil, I will say, when you do any kind of approach, you should have one cistern in your approach to release CSF. See? And this idea, the trauma, I think it works. I don't know for the brain that hypoxia severe, that you open, everything come out, is terrible. You cannot see even the skin. But some case that you can relax and give more blood supply to the brain, I think is a great idea. And the people has to start to do it. Before say it doesn't work, let this try. And you see the difference. Now we are doing our case, not in every case, and the patient has severe brain edema, severe brain swelling. We are not doing, because sometimes it's difficult to go down, but if the patient has a subdural hematoma, acute subdural hematoma, you are going there, open the cistern, have the contusion, you go there, open the cistern, take CSF leak, and the brain relax, and the blood supply come to the brain. I think this amount of blood that we gave the opportunity to reach the brain can be one factor to help in the brain. I don't know. It's my I see Professor Ben is here. Hello, Vladimir.
Hello, Luis. How are you?
I would like to hear you. You are
Can I continue?
that you are following during many years.
Yeah. We've known each other for many years, Luis, and I fully agree with you. This was rather nice what you have said. You must remember the old article of Paul Busey, who was resecting uncus in trauma patients. And actually, that was nearly the same procedure. He also had to open the cisterns to resect the uncus. I never understood why this procedure, which was rather straightforward and simple, was abandoned. That's one fact. But the other fact is that we all know that in neurosurgery we have 5 big circles. It's tumors, vascular, functional, spine, and trauma. And trauma, brain trauma itself, it hasn't changed too much since mid 20s. No, nothing really happened. We are still decompressing the brain. We are still just doing cosmetics from what was started on the road. You know, we are doing nothing more but cosmesis. And suddenly there appears a new procedure which might be beneficial. That's an analog to supine hemorrhage, of course. And thanks to Ipe, and I've known him for many years, and I guess that the first thing that when we have met and I said my name, he told me Cisternostomy instead of his name, you know, and since that I'm hearing only this from him. A little more, sorry. And I believe that despite all the evidence which is coming from trauma people, despite all the criticism, and if you read the criticism which was attached to Roy's article in ACTA, it was rather severe, but rather centered on technical issues only. It's not technical. I don't know who has said it just before me. It's not about the microscope, no microscope. It's not about anything like that. It's really about the concept. And the concept is bringing, in my mind, something new to neurotraumatology. And we should be the ones to pursue it, and we should be the ones to give it a chance. Luis, would you agree with that?
Yes, 100%. It's
Thank
about physiopathology, not about the surgical technique. It's physiopathology.
Exactly.
To understand different way and approach different way the disease.
Yeah.
You go there, you give to the resident, go there and do decompress. It's very easy to say. Go there and do the junior resident, the junior faculty, go there and do the decompress. Same happen.
Yeah. Trauma is the field where all the youngs are learning their techniques. It's the first thing you do when you come to the department as a young resident. It's trauma. And when you get older, you just leave trauma. You know, only those who are not able to manage, and I'm saying it rather harshly, who are not able to manage in other fields of neurosurgery, in more reconstructive ones, are staying behind in trauma. This is very, very harshly said, but this is my ultimate feeling.
Professor, do you remember the shunt? Many years ago, the DVP shunt was the last surgery in the day. Nobody want to do. Who will do the shunt? Give to the medical student, you see?
Right.
And very high level of infection, very high level of dysfunction, very high level of misposition. And the people, I think from France, Professor Maurice Chou, with his experience in brain tumor, he started to talk about shunt.
Right.
Why shunt? He said that was the first surgery in the morning, that the room was completely clean, few people inside the room, and they changed the way to treat DVP, the hydrocephalus and DVP shunt.
Yeah.
Maybe the trauma,
surgery.
you are still doing the same thing.
Yeah. 18 minutes surgery for shunts, if you remember that. But since then, we all are having shunts as number one in DORs. I don't know about you, but we do that.
Yes, for us.
Yeah. And the trauma, you know, in trauma, it's always difficult to prove something because actually we are talking about very heterogeneous degree of concussions, degree of consciousness disturbances, whatever, you know. It's not really one single disease like, let's say, clinoid meningiomas, which are uniform. This is very heterogeneous. So to prove something, you need really huge numbers to be able to prove some idea. And that's something which might be difficult in anything to pursue trauma further.
We need to stimulate. We need to stimulate a cooperative study.
Exactly.
Many people is doing around the world. But people say, and a few people is writing. Maybe you should do more cooperative study around the whole world that you can prove. Maybe not work to every case, but some select case will work. I think so.
You know, quite a few days ago, I had a lady patient with low back pain, severe, unresponsive to any treatment. And the only finding she has had was a Tarlow cyst, you know, a huge one. And I only then realized, talking to her, that the patients themselves do divide us neurosurgeons into two groups, believers and non-believers in Tarlow cyst, if you operate them or not, you know. So in that way, I'm unbeliever. But in Cisternostomy, this is now the same situation, that we are believers and non-believers. And it's up to IPE to prove it, to organize some huge study and to prove the concept. You might be famous, IPE.
Thank you, Luis and Vlad. You both are big stars. It's always an honor to have you guys, and you are as close as friends can be as well. So it's always good to have you to come and say something in these kind of meetings. You know, we are in a stage where I remember 2007 when I started talking about cisternostomy, the kind of response that I used to get. I have transformed from, I say, the palace joker to the confuser, people who confuses, somebody who confuses everybody. Then to some people started believing in me. Then I became somebody who fights with everybody, because I thought, you know, I was talking sense and people were, you know, shooting me down for it. So I realized that I will stand up. And when that happened, I was the guy who fought with everybody. Then I started to convince a few people. And now we have come to a stage where, you know, people are talking about a trial and things. I'm happy everything happens slowly, but I'm sure once people do cisternostomies and realize that the change that they see compared to DC, I'm sure people will change. Science has never been my strong point. Literature, writing papers, as Sabarish said, in 13 years, 4 papers have come out, and that too because of people like Hira or somebody else who's helped me, who's literally caught my neck and asked me to get all my data out. And, we were never very well prepared. I was busy operating, I could never write. And I guess that's probably why I don't like papers too much, or all these reviewers who used to send me very, very nasty comments. I mean, so nasty that sometimes, if they were not in Europe or something, I would have gone and I would have just walked there, opened the door and kicked their ass, that nasty sometimes. As if, you are some kind of base animal who doesn't deserve anything. And that's the kind of attitude people had. So probably that's why I fought with a lot of people. But now it's coming of age. Now I'm understanding a lot of people who are doing it are understanding the same. So I guess I'm becoming a bit more mature. And people like you, Vlad, Luis, and many more people are understanding and supporting us. And a lot of people like Wang, Roy, they're doing it and they are also understanding. They are turning believers as well. And as Vlad said, it's always about two communities, believers and non-believers. I realize that you cannot convert one to another. You just really don't need to, You just need to do your work and go ahead with it. Of course, I would like to, for the greater benefit, as people say, I would like people to turn to it. But now I've stopped pressing it and pushing it or anybody. If somebody wants to do DC, let them do it. Somebody wants to open the systems, I'll be happy to help. But there's no pushing it on anybody. It's a free world. We are not yet slaves, so it's a free world. Anybody wants to do something, it's as long as we believe we are doing the best for our patient, anything is acceptable. But as I said, as everybody said, microneurosurgery has to come to trauma. There's no other way. It is, as Vlad said, we are still in the 1920s with trauma, and that's not acceptable. So we have to change. Thank you so much. Nilesh, the next